Hi, everyone. Today we are going to dive into ICD-10-CM Chapter 1, which is certain infectious and parasitic diseases. We have updated this fiscal year 2025, the certain infectious and parasitic diseases for ICD-10-CM Chapter 1. The key lesson concepts for today are to understand the classification and chapter-specific coding guidelines for infectious and parasitic diseases, identify the different categories of infectious diseases and their coding requirements, and then gain proficiency in assigning accurate ICD-10-CM codes for infectious and parasitic diseases. At the end of the lecture, we'll go over quite a few case examples together on how to look up the codes for these sections. As we go through the guidelines, don't feel like you have to memorize them all. As we go through these chapter-specific guidelines, they will start to make more sense once we start looking up the codes and we start applying them at the end of the lecture. So just turn to your books on page 457. If you have the AE, if you have a different one, it might be on a different page, but this is where our Chapter 1 ICD-10 chapter-specific guidelines start for infectious and parasitic diseases. You may want to make a few notes or highlight as we go through. So let's get started. Let me open up the guidelines, and actually the document that I'm going to go through is the same guidelines that are in your book. It's just in a PDF format where I've added some of my own examples in. This will be in your course section. So if you want to have this document handy and print it off, that is fine. So if you're listening on YouTube and you would like a copy of the Chapter 1 specific coding guidelines with all of the examples that we're going to go over, I've put the link in the description below to a free copy of the one that I made with all the examples in them. And this is a perfect chapter to have this for because, again, there's so many coding and sequencing rules in this chapter, especially for the inpatient setting. So if you want a copy, just feel free and click on the link and I'd be happy to send you a copy. We will be doing this for every chapter that we go through and have some case examples in there. And we're not going to go through all of these guidelines because there are a lot and it's just too overwhelming. This is your first chapter that we're getting into. I know we've practiced and we've gone over quite a few lookups, code lookups and how to look up a code. But again, this is really starting off a little bit complex. The infectious and parasitic diseases chapter is full and it's a long chapter. So just take your time and don't feel like you have to memorize and know everything. It will start to make more sense as we go through and we do the case examples at the end. Okay, and again, we're not going to go through every single guideline because it would be way too overwhelming. So we're just going to hit the main ones that are used most frequently, and we're going to go through the ones that are going to be most applicable for the inpatient setting and for this course. Okay, so Chapter 1, again, is the certain infectious and parasitic diseases. The chapter-specific guidelines are to be used in addition to the general coding guidelines and conventions that we've already went over in the course. So the first guideline we have here is for HIV infections. And the very first guideline says code only confirmed cases. Now, we went over a principal diagnosis guideline that said at the end of the stay, if a condition is listed as probable, likely, suspected, or similar terms, that you could still code it as such. Now, this is an exception to that rule. HIV infections and HIV disease or AIDS can only be coded if it is a confirmed case. So that's what this guideline is telling us. So for example, if a patient is admitted with pneumonia and possible HIV infection documented at the end of the stay, we would only code the J18.9 for the pneumonia. So the second guideline is selection and sequencing of HIV codes. Patient is admitted for an HIV-related condition. If a patient is admitted for an HIV-related condition, the principal diagnosis should be B20, human immunodeficiency virus disease, followed by an additional diagnosis for all reported HIV-related conditions. An example of this is a patient is diagnosed with AIDS-related Kaposi sarcoma in the left lung. Our principal diagnosis will be B20, followed by the Kaposi sarcoma, which is C46.52. An exception to this guideline is if there's reason for the admission is hemolytic uremic syndrome associated with HIV disease, assigned code D59.31, infection-associated hemolytic uremic syndrome, followed by code B20, HIV disease. And that's going to be similar for our COVID as well, and we will get to that. But the hemolytic uremic syndrome is going to be sequenced first, as you can see here. So a patient who is admitted, an HIV disease patient who is admitted for an unrelated condition, then we are going to code again, if the circumstances of admission are for the unrelated condition, we are going to code that unrelated condition as the principal, followed by the code for the AIDS or HIV disease, which is B20. So if a patient is admitted for acute kidney injury unrelated to HIV disease or AIDS, our principal diagnosis is going to be N17.9 for the acute kidney injury. HIV disease or AIDS is going to be a secondary. Similar would be a fractured ankle, and the patient has HIV disease. The fractured ankle would be the principal, and B20 for the HIV disease would be a secondary. The code for an asymptomatic HIV patient is Z21. That is, if the patient is HIV positive, they have known HIV test positive, or similar terminology, that is going to be Z21. Again, we only code confirmed cases of HIV disease, which is AIDS. Someone can be HIV positive, but not necessarily have AIDS, full-blown AIDS. We do not use this code if the term AIDS or HIV disease is used, or if the patient is treated for any HIV-related illnesses or is described as having any conditions resulting from his or her HIV positive status. Again, Z21 is if you're HIV positive. B20 is going to be if you have HIV disease or AIDS. Basically, this is what this guideline is saying. Previously diagnosed HIV-related illness. Patients with any known prior diagnosis of HIV-related illness should be coded to B20. Once a patient has developed an illness, the patient should always be assigned code B20 on every subsequent admission or encounter. Patients previously diagnosed with any HIV illness should never be assigned R75 or Z21, asymptomatic HIV infection status. So basically, once a patient has been diagnosed with AIDS or an HIV-related illness, they are always going to stay in the same category. They're never going to revert back to that Z21, which is just HIV positive. Remember, our documentation is always the guide. Okay, moving on from HIV, we're going to look at infectious agents as the cause of diseases classified to other chapters. Certain infections are classified in chapters other than Chapter 1, and no organism is identified as part of that infection code. In these instances, it's necessary to use an additional code from Chapter 1 to identify the organism. A code from category B95 for Streptococcus, Staphylococcus, and Enterococcus as the disease is classified to other chapters, B96 other bacterial agents as the cause of disease classified to other chapters, or B97 viral agents as the cause of disease classified to other chapters, is to be used as an additional code to identify the organism. An instructional note will be found at the infection code advising that an additional organism code is required if known. So here's an example, and we have a urinary tract infection. This is an example of an infection that is listed in another chapter for urinary tract infection. But if we know the organism that is causing the urinary tract infection, it is telling us in red there, use an additional code from B95 to B97 to identify the infectious agent. And remember from our guideline review that we did, a use an additional code note is a sequencing rule where the B95 to B97 would always be a secondary and the N39.0 would be the principal if it met the definition of principal diagnosis. Some infections are resistant to antibiotics and the documentation will say that. So it is necessary to identify all infections documented as antibiotic resistant. Assign a code from category Z16, resistance to antimicrobial drugs, following the infection code, only if the infection code does not identify drug resistance in its title. For example, patient is being treated for a bacterial pneumonia that is resistant to vancomycin. The codes would be J15.9 for the pneumonia and Z16.21 would show the resistance to vancomycin. Here we can see this in the alphabetic index. This is a snapshot of the alphabetic index, and our main term is going to be resistant or resistant to, and then the organism to a drug, and then vancomycin. And we can see that's how we get to the Z16 point. Okay, moving on to sepsis. Sepsis, seemingly, based on all the guidelines that are listed here, can be kind of tricky to code depending on what's going on with the patient. However, if you follow your guidelines and you follow these examples, it really does become quite easy. So first, let's look at the coding of sepsis and severe sepsis. That is the first guideline that we see here. So for a diagnosis of sepsis, assign the appropriate code for the underlying systemic infection. If the type of infection or causal organism is not further specified, assign code A41.9, sepsis, unspecified organism. Okay, so when they're talking about the systemic infection, they're talking about the A41.9, or for instance, down here, we're going to see A41.51. That is going to be our systemic infection, okay? That's where we go to the alphabetic index. We're going to look up sepsis, and then it's going to lead us to our code, and that is going to be our systemic infection. So a code from subcategory 𝗗65.2 for severe sepsis should not be assigned unless severe sepsis is documented or an associated acute organ dysfunction is documented, because the definition, according to ICD-10-CM, of severe sepsis is sepsis with an associated acute organ dysfunction. So in the example that we have here, we can see for E. coli sepsis, just in and of itself, the code is going to be 𝗗41.51, and we would look that up in the alphabetic index under sepsis, and then E. coli, and we would get to 𝗗41.51. And then if we have E. coli severe sepsis with associated acute kidney injury, we have the same code for the 𝗗41.51, which is our systemic infection. We have an additional code for severe sepsis, which is 𝗗65.20, and we also have N.9, which is going to represent our acute kidney injury. Okay. So here we have a very important guideline that's used frequently. So negative or inconclusive blood cultures and sepsis. A negative or inconclusive blood cultures do not preclude a diagnosis of sepsis in patients with clinical evidence of the condition. However, the provider should be queried if there is any conflicting documentation. So for instance, it's very common when someone comes in with an infection that the first thing they do is draw blood cultures. And the patient may have clinical signs and symptoms or meet the clinical criteria for sepsis, and that's documented. It means that if the blood cultures come back negative for a bacteria in the blood, it doesn't preclude the diagnosis because the patient very well could still be septic. Again, another very important guideline, urosepsis. This is a term that is used by providers sometimes, and it's unclear whether they are trying to say that the patient has a urinary tract infection, like a localized infection, or do they truly have sepsis that's due to a urinary tract infection. So this guideline says the term urosepsis is a non-specific term. It is not to be considered synonymous with sepsis. It has no default code in the alphabetic index. Should a provider use this term, he or she must be queried for clarification. I can promise you, you're going to see that again throughout the course, so please make a note and highlight that. So sepsis with organ dysfunction guideline is basically just reiterating what we just talked about. If a patient has sepsis and associated acute organ dysfunction, ours was acute kidney injury, or multiple organ dysfunction, follow the instructions for coding severe sepsis. Acute organ dysfunction that is not clearly associated with the sepsis. So if a patient has sepsis and an acute organ dysfunction, but the medical record documentation indicates that the acute organ dysfunction is related to a medical condition other than the sepsis, do not assign a code from 𝗗65.2 severe sepsis. So for instance, if the patient comes in and they have acute kidney injury or acute tubular necrosis, say, that's due to a contrast that they received during a procedure, and they also have sepsis. And we cannot make a connection just because the patient has an acute organ dysfunction like acute tubular necrosis, because the provider has linked it to another condition. So we wouldn't be able to get that severe sepsis out of that because the provider has linked that organ dysfunction with a different underlying cause rather than the sepsis. So here we see an example of acute kidney failure due to sepsis. In the alphabetic index, we see sepsis with organ dysfunction, and that's 𝗗65.20. That means that we can automatically get to code 𝗗65.20 when we have documentation that an organ dysfunction is due to sepsis. The provider doesn't even have to say severe sepsis. We have the acute kidney failure due to sepsis, and we can see that here. Now, again, in the example where that link is broken and we have acute kidney failure or acute tubular necrosis due to contrast dye and not sepsis, then this would not apply. And then we see failure kidney acute, and we have the N17.9. Let's look at this. Sequencing of severe sepsis. If severe sepsis is present on admission and meets the definition of principal diagnosis, the underlying systemic infection should be assigned as the principal diagnosis, followed by the appropriate code from subcategory 𝗗65.20 as required by the sequencing rules in the tabular. A code from subcategory 𝗗65.2 can never be assigned as the principal diagnosis. When severe sepsis develops during an encounter, it was not present on admission, the underlying systemic infection and the appropriate code from subcategory 𝗗65.2 should be assigned as a secondary. So again, we have our same example here, and we can see this is our systemic infection, the 𝗗41.51 for our E. coli severe sepsis with associated acute kidney injury. And then we have severe sepsis as a secondary, which again, this guideline is telling us it can never be the principal, and we put the systemic infection first. And then we get N17.9 for acute kidney injury. Now, severe or severe sepsis with a localized infection. In the the reason for the admission is sepsis or severe sepsis and a localized infection such as pneumonia or cellulitis, a code for the underlying systemic infection should be assigned first, and the code for the localized infection should be assigned as a secondary. If the patient has severe sepsis, a code from subcategory R65.2 should also be assigned. If the patient is admitted with a localized infection such as pneumonia and sepsis or severe sepsis doesn't develop until after the admission, the localized infection should be assigned first, followed by the appropriate sepsis or severe sepsis code. So let's go back up here to our example and let's pretend that this patient has a urinary tract infection and it's due to E. coli, and they have severe sepsis with acute kidney injury and a urinary tract infection that is the local infection that is causing this systemic infection, okay? So we have 𝗙𝗵𝗽𝗶𝗃. We would also then have a code, which we will see later. We'll see an example of this when we go through our questions at the end. But our secondary code would be for a UTI, which would be N39.0. We don't see it here, but that would be the code. That's going to be our local infection. And then we have severe sepsis and AKI. So this A41 category is always going to be the principal, unless we have a complication, and we'll get to that later. But that is going to encompass the systemic infection, and that is going to always be the principal if it meets that definition of principal diagnosis, followed by, if it's present on admission too, that really does matter. We went over present on admission status in Chapter 5, so it would have to be present at the time of admission. And then our local infection is going to go second, such as urinary tract infection, pneumonia, cellulitis, then a code for severe sepsis, and then N17.9. And I should remind you that, again, I know you're really new to looking at codes and the coding of these things. And really, when it comes to sequencing, we're really focused on the principal diagnosis. All of the secondary diagnoses can be in any order. We're really just focused on sequencing the principal diagnosis. We don't have to put in order any secondary diagnoses. We're going to come back to post-procedural infections when we get to the T codes, when we look at the T code section. So let's table that for now. Okay. We're moving on now away from sepsis. So for methicillin-resistant staphylococcus. Okay, so for conditions, selection and sequencing of MRSA codes. So combination codes for MRSA infection. When a patient is diagnosed with an infection that is due to methicillin-resistant Staphylococcus aureus or MRSA, and that infection has a combination code that includes the causal organism, for example, sepsis, pneumonia, assign the appropriate combination code for the condition. For example, 𝗙41.02, sepsis due to methicillin-resistant Staphylococcus aureus, or code J15.212, pneumonia due to methicillin-resistant Staphylococcus aureus. In this case, do not assign a code B95.62 for methicillin-resistant Staphylococcus aureus infection as the cause of diseases classified elsewhere as an additional code, because the combination code includes the type of infection and the MRSA organism. We also do not assign a code from subcategory Z16.11 resistant to penicillins as an additional diagnosis. So we don't need to double code and also represent it with a Z code to say that this is resistant to penicillins, because our code title already describes that for us, okay? So other codes for MRSA infection: when there is documentation of a current infection, such as a wound infection, a stitch abscess, a urinary tract infection due to MRSA, and that infection does not have a combination code that includes the causal organism, assign the appropriate code to identify the condition along with B95.62, methicillin-resistant Staph aureus infection as the cause of disease classified elsewhere for the MRSA infection. Okay, so in this example, let's say the patient presents for a UTI due to MRSA. Our urinary tract infection code doesn't say anything about MRSA, so we need an extra code to fully describe this condition, okay? So that would be the B95.62 for the MRSA infection. And that way, we have a complete picture of what's going on with the patient. Okay, so methicillin-susceptible Staph aureus and MRSA colonization. The condition, this is very common. So the condition or state of being colonized or carrying MSSA or MRSA is called colonization or carriage, while an individual person is described as being colonized or being a carrier. Colonization means the MSSA or MRSA is present or in the body without necessarily causing illness. A positive MRSA colonization test must be documented by the provider as MRSA screen positive or MRSA nasal swab positive or similar terms. Then we would assign a code from Z22.322 carrier or suspected carrier of methicillin-resistant Staph aureus for patients documented as having MRSA colonization, Or we would assign Z22.321 carrier of suspected MSSA for MSSA colonization. Colonization is not necessarily indicative of a disease process or the cause of a specific condition the patient may have unless documented. So it's interesting because a patient can actually be a MRSA carrier or have colonization, and they can also have a MRSA infection at the same time. And if that's the case, if a patient has a documented as having both MRSA colonization and an infection during the same hospital admission, code Z22.322 carrier or suspected carrier of MRSA and code for the MRSA infection may both be assigned according to this guideline. For coronavirus, here we go again. So code only confirmed cases. So again, not to keep repeating, but if the provider documents suspected, possible, probable, or inconclusive COVID, do not assign the code for 𝗙𝗵𝗽𝗶𝗰. Instead, code the signs and symptoms reported with COVID. Okay, so sequencing of COVID codes. When COVID-19 meets the definition of principal diagnosis, code 𝗙07.1, COVID-19 should be sequenced first, followed by the appropriate code for any associated manifestations, except when another guideline requires that certain codes be sequenced first, such as obstetric, sepsis, or transplant complications. So as we know, COVID is an infection, and sometimes COVID patients will come in with sepsis as well. So that sepsis guideline tells us that our systemic infection is going to be sequenced as the principal diagnosis. And then if we have pneumonia, COVID pneumonia, which here we can see in the alphabetic index pneumonia, COVID-19, which would be J12.82 because it's a specific identified pneumonia. If we go to the tabular list, we can see that we have a code first note, which would be code first COVID-19 U0.1. And then we have here another reminder for a COVID-19 infection that progressed to sepsis. See section 1C1D, sepsis, severe sepsis, and septic shock. Okay. Again, all the manifestations are going to be secondary codes after the COVID-19. This is basically what these are going through now. Okay, so the last thing we're going to look at as far as chapter 1 goes is the sequela of infectious and parasitic diseases, which is B90 to B94. And category B90 to 94 are used to indicate conditions in categories A00 to B89 as the cause of sequela, which are themselves classified elsewhere. The sequela include conditions specified as such. They also include residuals of diseases classified to the above categories if there is evidence that the disease itself is no longer present. Code from these categories are not to be used for chronic infections. Code chronic current infections to the active infectious disease as appropriate. So in this section, we can see we have a code first note, code first condition resulting from sequela, the infectious parasitic disease. And we have an example here. So if we had sequela from viral encephalitis, and remember, we went over sequela in our ICD-10-CM general coding guidelines and what a definition of sequela is. And basically a sequela is a residual effect of a condition that was previously current. So here we have a sequela of viral encephalitis would be B94.1. And what the code first note is telling us in the tabular is code first, the condition resulting from the sequela, the infectious or parasitic disease. So basically this would be a patient who in the past had viral encephalitis, and now they're having some residual effect from that. And we will see that as an example in one of our questions. Okay, so let's look through some questions and see how we do. And we'll bring this all to life so we can see how we start to code some of these conditions and some real life examples of how to bring these coding guidelines to real life. Okay, so first, we have an 82-year-old male who was seen with fever, malaise, and painful urination. A urinalysis was performed and showed bacteria. This was followed by a culture showing E. coli growth as the cause of the urinary tract infection. Let's pause the recording and come back and we will go over this together. Okay, so coming back again, we have our patient with urinary tract infection that's due to E. coli. So if we go to urinary tract infection, which is N39.0, that is going to be our code. And again, we looked that up in the alphabetic index under infection is going to be our main term. If you want to go to your alphabetic index and find that. And then we're going to, our next subterm is going to be urinary, and that is going to lead us to the N39.0, okay? Then we want to turn to the tabular, and what is up on the screen here is a snapshot of what is in the tabular. So we have urinary tract infection, site not specified, But here we see use an additional code from B95 to B97 to identify the infectious agent. In our case, we have B96.20 for Escherichia coli as cause of disease classified elsewhere. Now, if we wanted to look up the Escherichia coli in the alphabetic index, we would simply go to Escherichia coli, and then the very first default code is as cause of disease classified elsewhere, which is our B96.20, which is exactly what we have. And if you look at this, you can tell that the Escherichia coli, it's perfect. Escherichia coli as a cause of disease classified elsewhere, and that elsewhere is our urinary tract infection. Now remember from our coding guideline review that we did last week that the symptoms of fever, malaise, and painful urination would not be coded separately as they are considered routinely associated with a UTI. Signs or symptoms that are associated routinely with a disease process should not be assigned as additional codes unless otherwise instructed by the classification. All right, so let's go back and do another one. So here we have a 25-year-old female is seen for pelvic pain due to pelvic inflammatory disease. The source of the PID is a result of a sexually transmitted chlamydia. We're going to have one code for this condition. Pause the recording and look up the code in the index and the tabular and see if you can get it. Okay, so here we have some key terms. We have a 25-year-old female who is seen for pelvic pain due to PID. The source of the PID is a result of sexually transmitted chlamydia. So if we go here on the right, we have a snapshot of the alphabetic index, and we can see chlamydia as our main term. And then if we scroll down, we need to know that this is a female patient. So that is going to be our next subterm, female. And then we see pelvic inflammatory disease, and that's A56.11, okay? And then if we go to the tabular, we have A56.1, and we can see chlamydial female pelvic inflammatory disease. We have only one code here because our organism and our infection are all under one code. This is how this differs from the previous example where we just had a urinary tract infection that didn't explain the underlying bacteria, so we had to have two codes. Again, note that the symptom pelvic pain would not be coded separately as it's considered routinely associated with a pelvic inflammatory disease, and that is in keeping with our guideline 1. Signs or symptoms that are associated routinely with a disease process should not be assigned as additional codes unless otherwise classified. Okay, another example is a 30-year-old HIV positive female has a fever and shortness of breath. The diagnostic workup, including chest x-ray and sputum culture, resulted in a diagnosis of pneumocystis pneumonia due to AIDS. Okay, so we have AIDS and we have a pneumocystis pneumonia. So we have two codes here, and we want to put them in the correct order according to our guideline. We first have to look up the codes in the alphabetic index, and then we want to go to our tabular and look at any instructional notes and look at our guidelines and how we would code this. Pause the recording and see how you do. Okay, so if we go to our alphabetic index and we look up pneumonia, and we scroll down under the subterms, we have the other subterm of pneumocystis, and we get B59. And then if we go to the tabular, we see B59 is going to be our code for the pneumocystis, okay? Now, again, our guideline that we are going to reference is in Chapter 1, and that guideline says when we have an AIDS-related condition, in addition to AIDS, our AIDS or our HIV disease code is going to be principal, and a secondary code for the associated infection. That would be B20 as first and B59 as a secondary. Okay, so our next example, we have a 93-year-old being treated with IV antibiotics for E. coli severe sepsis, UTI, and acute kidney injury due to sepsis. Pause the recording and see how you do. Okay, so here's our answer for the 93-year-old being treated with IV antibiotics for E. coli severe sepsis, UTI, and acute kidney injury due to sepsis. So our first code here, we're going to look up sepsis, and then we're going to see Escherichia coli, and that's A41.51. We also have with organ dysfunction because we have acute kidney injury that's due to sepsis, and that would be our 65.20. And then we can see here that the A41.51 confirmed in the tabular is sepsis due to Escherichia coli. We're going to have our urinary tract infection, which we would go to the alphabetic index and look up main term infection, urinary tract, and that's N39.0. And just a reminder here, we don't need that B code for the E. coli because we already have the fact that the E. coli is a causal organism associated with our sepsis and our infection represented in our sepsis code here. So we wouldn't need an extra B code to identify the E. coli in this situation. And then we also have severe sepsis, the 𝗙65.20, because again, we have our organ dysfunction. And down here, I just want to point out with our severe sepsis code, under the severe sepsis subcategory here, we have this code first note. Let me see if I can zoom in just a smidge. Code first, the underlying condition. So if there was any doubt, we already have the guidelines that tell us to do this, but it's nice because in the tabular, we have these instructional notes that remind us as well. So when we get to severe sepsis, we can automatically see in red here that we code first any underlying infection, such as, and in our case, that's going to be the 𝗙𝗵𝗽𝗶𝗴𝗶. This is not an all-inclusive list, so it's just giving us some examples of what would be coded first. And in our case, the systemic infection, which our guideline told us to do, is going to be 𝗙𝗵𝗽𝗶𝗴𝗶, and that is going to be our principal diagnosis. Here we have a 65-year-old female. She was taken to the emergency room after being found semi-conscious with markedly abnormal vital signs, a fever of 101.4, heart rate of 100, and a respiratory rate of 22. To the ICU, the physician documented severe sepsis with acute respiratory failure. The final diagnosis provided by the physician was gram-negative sepsis with associated acute respiratory failure. Let's pause the recording and see our answers. Okay, so let's look here, and here we have our sepsis with organ dysfunction, and we see here we can get to the 𝗙65.20 because we have an associated organ dysfunction. Even though the provider didn't document severe sepsis, when we have it linked, the organ dysfunction is linked to the sepsis, we can get the 𝗙65.20. Now, the documentation has to support that linkage, and if it does not support the linkage, and or if it unlinks the organ dysfunction with the sepsis, remember, we can't get to the 𝗙65.20. Now, we also have a gram-negative sepsis, so we need a code for our systemic infection, which is going to be 𝗙41.50, and this is what our final coding is going to look like. 𝗙41.50 for the gram-negative sepsis, 𝗙65.20 for severe sepsis, and J96.00 for acute respiratory failure, unspecified whether it was with hypoxia or hypercapnia. Okay, those are our three diagnoses. Okay, so here we are. We have a 32-year-old man who was transferred from an outside facility for treatment of septic shock, acute meningococcal sepsis. The outside facility was unable to manage his severe illness. What are the two codes that we're going to assign? Pause the recording and let's check the answers in a couple minutes. Okay, so our first code is going to be sepsis meningococcal acute, and we would get to that by looking up in the alphabetic index under the sepsis and then meningococcal. We would get to the shock by going to shock, septic, and we get 𝗙65.21. Our next case is a 45-year-old female with known chronic viral hepatitis resulting from hepatitis B. She is seen for initiation of antiviral therapy. What is the code for the chronic viral hepatitis resulting from hepatitis B? Chronic type B. Now, if you go to your alphabetic index and you go to hepatitis, there we're going to then go to subterm viral, and then under that, we're going to go to chronic and then type B. And we only get one code for that because that code fully describes the condition. Okay, moving on to a patient, 45-year-old male patient who has HIV disease and is admitted with a traumatic left ankle fracture. Pause the recording and see how you do. Okay, so first we have the patient, and again, they're admitted for treatment of a traumatic left ankle fracture. And if we think about the coding guideline that we looked at previously, where it said when a patient comes in with HIV disease, but the reason for the admission is an unrelated condition, then we would code that unrelated condition as the principal diagnosis. In our case, we have a treatment for a traumatic ankle fracture. So here we would look up fracture, traumatic, and then we go to ankle. And then as we scroll down, we see that it's of the left lower leg. So that's S82.892. And then we need our A code, which we can find. And again, we're not going to go looking for that now because when we get to the fracture section, we'll be looking more in the tabular for those. But we need a 7th character. Our little indicator here next to the code tells us we need 7 characters. And in this case, it is going to be A because it's an initial encounter. And that can be found at the category level. But again, we're not going to do that now because we're really focusing more on our infectious diseases. But then we also have HIV disease, and that can be found in the index under disease. And then human immunodeficiency virus, which is HIV, and that's going to be B20. They're going to be sequenced in this order because our guideline tells us that when a patient comes in for an unrelated condition, and that meets the definition of principal diagnosis, that condition is going to be our principal diagnosis. Next, we have a 25-year-old female patient who presents with a new onset convulsion that is a result from a previous viral encephalitis. Now remember, we should be starting to think when we have a condition, a current condition that is a result of a past condition, that word sequela should start to be festering in our mind. And in this case, we have a new onset convulsion, but it's due to a previous resolved viral encephalitis. So we don't have an active encephalitis right now, but we have a previous viral encephalitis. So I want you to pause the recording and see if you look this up, and then we'll go over it together. So in our case, we would have a convulsion that was due to a previous encephalitis. So we're going to have 𝗗56.9, and then we're going to have sequela of viral encephalitis. And the way that we would look that up in our alphabetic index is we would go to sequela, and then we would turn to viral is our next subterm, and then we would go to encephalitis, and we get the B94.1. Now, when we get to B94.1 in our tabular list, we can go there now. We see we have sequela of viral encephalitis for B94.1. But if we go up to the category level, so where it says sequela of infectious and parasitic diseases, and its categories B90 to B94, we can see that ever important code first condition resulting from sequela, the infectious or parasitic disease. So we have a code first note, which would mean that our 𝗗56.9 for the convulsion would go first, and our sequela of the viral encephalitis would be second. So here we are at sequela, and we want to look up a sequela of viral encephalitis. So we're going to turn, and we're going to look up under main term sequela here at the top. We're going to scroll down, and we can see viral encephalitis, which is B94.1. Okay, then let's turn to the tabular and go to B94.1 for instructional notes. And this is just going to reinforce the coding guideline that we did earlier in the lecture. And we're going to see here that for sequela of infectious and parasitic diseases, which is the categories that we're in, that we code first the condition resulting from the sequela, the infectious or parasitic disease. So we have B94.1, sequela of viral encephalitis, and then our convulsion is going to be coded first, and we simply would look up a convulsion that's not further specified in our alphabetic index as convulsion. So here we have convulsions. Our convulsion isn't further specified into any type of seizure, it just says convulsion. We don't have any further specificity, so we're just going to use the 𝗗56.9, okay? So that is how we get to our final code, 𝗗56.9. And that's it, guys. That's the end of our lecture for Chapter 1 for infectious and parasitic diseases. Please reach out with any questions.